Hopefully you guys don't hear any kind of feedback because I have the chat on my phone.
Nope, we're recording. You're ready to go whenever you're ready.
Perfect. All right, well, good morning. Thanks for joining us for case reviews for January. I hope that you guys had a good December and the end of your year. A couple of cases that we'll review occurred over the last couple of months. As always, the information that's contained here is confidential and private. It's protected by HIPAA, and use, distribution, or copying is not allowed. Let me try to make my. All right, so going on to case review, case number 1. 63-year-old male who EMS found in bed. They initially were notified of a patient with flu-like symptoms. PPE usage reported was maximum. First set of vital signs occurred 10 minutes after patient contact, noted to be tachycardic at a heart rate of 108, blood pressure of 177 over 108, respiratory rate of 20, GCS of 15, SpO2 was documented as 92%, and his weight was 100 kilos. They noted that he was awake, his airway was open, he was protecting, his pulse was present, he was diaphoretic. They document that he was very hot to touch and that there's no signs of active bleeding. The past medical history that they reported was hypertension, and that the patient had provided the information that he was seen in the hospital the day before, the emergency room, and that his home temp was 105.2. He was experiencing chills, headache, myalgias, weakness, nausea, vomiting, and for which he had taken Zofran and Tylenol at home prior to EMS arrival. So this occurred around 4:30 in the evening. At 10 minutes, sorry, someone's speaker is on. If you would like to mute yourself unless you have a question or a comment. I'm not sure if, Mark, that you could find that person.
Yep, got it.
Thank you. So the patient did provide additional information that he had returned from Ethiopia a few weeks earlier. He had declined any pre-vaccinations prior to his Ethiopia trip. EMS checked his temperature and it was 104.4 after Tylenol. At 23 minutes, his blood glucose was documented as 166, and he was given approximately a liter of IV fluids. Transport was initiated at 24 minutes, and at 25 minutes, the second set of vital signs were obtained, noted to be still tachycardic, a little bit improved. Blood pressure improved down to 147 over 77, and his SAT without supplemental oxygen had increased to 94% in that hospital arrival at 45 minutes. So what I thought, just looking over this case, is that they really did a good job of getting additional social history. They notified the hospital what they thought might be a potential dengue fever or malaria case. So appropriate concern notification relayed to the hospital beforehand. IV fluids were initiated, especially since this patient is sick, tachycardic, likely dehydrated with some GI complaints. I noticed that in the hospital setting that they had documented he had a history of diabetes, so that was missed in our review. And then if your patient is hypoxic at 92%, it'd be always a smart decision to do a lung auscultation, especially when you're dealing with hypoxia. That was not documented, but otherwise I thought this crew did a great job. In the emergency room, the patient had relayed the similar history, 4 days of headache, chills, fever, nausea, vomiting. Based off of his history, blood cultures were obtained. He had a CT done of his chest, abdomen, and pelvis that was unrevealing. And the ER doc had consulted the infectious disease doctor for appropriateness of workup, which was microscopy. They had done the thick and thin samples and noticed that he did have inclusions, significant for malaria. This patient was admitted. He was diagnosed with the form of Vivax malaria. He was treated with artemether lumefantrine at the discretion of CDC, which was consulted during his hospitalization. This particular strain of malaria has a high risk of acute respiratory distress or acute respiratory distress syndrome or acute respiratory failure. They did not repeat a CT because he wasn't having any complaints, but his initial CT was unremarkable, and they recommended that he remain as hospitalized until his peripheral smears were cleared. But the patient left AMA on hospital day 10. I did look at his previous presentation at the first hospital, and they worked him up kind of like you would expect with like a flu-like symptoms, as either the patient did not provide the information that he had recent international travel to an endemic area, or that they had just gone off of the patient's flu-like symptoms, tested him for flu, COVID, and I believe it was a chest x-ray as well, and then discharged. So this case was brought up to us by one of our EMS colleagues as a good case to discuss a not so common presentation. So malaria is mosquito-borne. The vector is the Anopheles mosquito, which I think I read up to 30 different varieties. And is caused by a Plasmodium parasite, and the host is humans. The incidence worldwide is about 241 million cases, with approximately 627,000 dying annually. Usually, these are going to be children under the age of 5, mostly related to South or Sub-Saharan Africa. There's approximately 2,000 cases a year in the United States, and the prevalence is predominantly in Sub-Saharan Africa, but also in South Asia. This map on the bottom right here shows you that the malaria transmission occurs throughout in the red area, and then somewhat in the yellow area, and not known to occur in the green area. So even travel to the Caribbean. I think I looked at one case from the Dominican Republic of a malaria positive individual. So malaria life cycle, first off, is that you get bitten by the Anopheles mosquito, and it has to be the female mosquito. Interestingly, male mosquitoes don't take a blood snack, I guess is how they described it. Only the females do in preparation for laying eggs. So if you have to be bitten by an infected female Anopheles mosquito, once they bite you, they release the sporozytes from their salivary gland, which infect the liver. Once in the liver, they multiply and are released, and the different stages start to affect the red blood cells. This continues on in the infestation or infection state in the blood cells, and this is the stage that is actually symptomatic. It's not the liver stage, but the red blood cell stage is the time when people start to be having fevers, myalgias, GI symptoms, and they'll continue to multiply until they develop male and female gametocytes. This takes up to, just making sure. So they develop gametocytes, and then they're ingested by mosquitoes that are taking a blood snack, I guess, again, from the human vector. And it takes up to 18 days for the gametocytes to form into the sporozytes, starting this whole cycle again. Interestingly, the Vivax and Ovale forms of malaria have a dormant stage that can last up to a year dormancy in the liver. So interestingly, this patient also was identified to have the Vivax form. The diagnosis of this condition is with thick and thin blood smears or microscopy. So kind of old school, someone has to look at the has to look at the slides and identify if they see early stages of the plasmodium. And then this picture down here gives you a timeline from 0 to 2 days of the stages of the replication in the red blood cells. One negative thick and thin smear is not adequate. You need to have 3 sets and repeated every 12 to 24 hours that are negative to be considered a negative for this condition. And then signs and symptoms are going to be fever, chills, headache, fatigue, myalgias, and nausea, vomiting. For the pre-hospital side of things, it's going to be similar to the hospital minus the treatment, which is ABCs, IV establishment, and then once we identify that they have malaria, we look at are they uncomplicated versus complicated and what species they have, which will indicate the appropriate treatment. Appropriate treatment, we probably have heard a little bit about that in the COVID days, but could be chloroquine, could be hydroxychloroquine, could be this lumefantrine, as well as a combination of different antibiotics depending on. Untreated, the mortality is pretty high, and that can lead to cerebral etiology, renal failure, heart failure, sepsis, and death. So in our protocol, we don't, not surprisingly, don't have a malaria protocol. So when I looked at our protocols, I think that the two that most significantly apply to this condition would be our universal patient care protocol. So identifying if you're seen safe and that it's safe to approach the patient and having a proper PPE usage for these patients. This would not be an issue for the most part unless you end up getting infected by the vector's blood, but that shouldn't be an issue from what I could gather on my looking through this, unless you're being bitten by a spider or a mosquito with that's infected. And then management of the nausea and vomiting. So identifying if the patient's in shock, and with your options would be Zofran or droperidol, predominantly just supportive. Any questions? I don't see any questions in the chat. So interesting, for sure. Next case is of a 65-year-old female found on the couch. EMS makes contact and identifies the patient as being unconscious. PPE usage is maximum for this patient. Vital signs are obtained 6 minutes after patient contact. Her heart rate's 54. Her blood pressure is 173 over 126. Her respiratory rate is 10. Her GCS is 3, and her room air stats are 96%. She's estimated to be 90 kilos, and the patient's unresponsive. Has an open airway, but she's not protecting it, and her pulse is present. They document that she's ice cold to touch. It would be helpful to have a little information about what was the temperature inside this house, because they do document that she was found on the couch in her own presumed home. She's pale and there's blood around her face. They noticed there was drug paraphernalia around her, so they assume her past medical history appropriately would be potentially related to substance abuse. And from what they documented, they suspected methamphetamine abuse. And the history provided was that the neighbor noted that her front door was open for the last 2 days. He didn't see anyone coming and going, and the door remained open. So he came over on the second day and found her on the couch, unresponsive, and he doesn't know her to provide any additional information about her. So there's a lot that happened in the 47 minutes. That's why the time stamps are so small. But because it's hard to see probably from your screen, I'm just going to briefly go through each one of them. So the only thing that they really document about the scene is that there's associated drug paraphernalia surrounding her. They make contact with her approximately 12:19 in the afternoon. At the first 4 minutes, they tried to get an IV. They were unsuccessful. If you just joined, can you make sure that you're on mute? At the first 4 minutes, they attempt to get an IV. They're unsuccessful, so they place intranasal Narcan, 2 milligrams. They wait a little bit. There's no response. At 6 minutes, those are the vital signs that I had mentioned earlier. The end-tidal CO2 was 24, and her IV was established, and she was given 1 liter of IV fluids. At 9 minutes, another set of vital signs are obtained, largely unchanged. At 11 minutes, they give her 2 milligrams of Narcan. This is her second dose now, IV. At 20 minutes, they note that she's still perfusing, at least her SpO2 is 97%, and they get a 12 lead. The 12 lead has a lot of artifact, especially in the first portions of it, but otherwise it appears to be sinus. It looks like she's got a QRS prolongation, potentially a left bundle. There's some abnormal morphology, but nothing specifically speaking out. At 21 minutes, they check a blood glucose. It's 100. They start to bag her and suction her. I believe they said there were some secretions. At 22 minutes, they move forward with RSI using 140 milligrams of succinylcholine and 30 milligrams of etomidate. At 23 minutes, they successfully intubate her with video laryngoscopy and bougie on first pass. And at 25 minutes, they initiate CPR for VFib. And they shock her. Well, I should step back. So at 26 minutes, they do shock her at 200 joules and they give her 1 milligram of epi. 3 minutes after that, they notice her to be in VFib again, so they shock her second time. A minute after that, they give epi. At 31 minutes, they initiate transport. Her SATs are 89%. At 32 minutes, they shock her at 360. At 33 minutes, they give her a milligram of epi. At 35 minutes, they shock her again at 360, and they give her 300 of amiodarone. They repeat another set of vital signs at 36 minutes, still in cardiac arrest. At 37 minutes, she's shocked again at 360. At 38 minutes, she's given another milligram of epi. At 39 minutes, she's shocked again at 360. At 41 minutes, they give her bicarb. At 42 minutes, she gets another shock. At 43 minutes, she gets 2 grams of mag. At 44 minutes, she gets another shock at 360. At 45 minutes, she gets another milligram of epi. And at 46 minutes, she gets another shock. And at 47 minutes, she makes it to the emergency room. So in all, in total, she's been shocked 9 times, and she's been given 5 milligrams of epi, as well as amiodarone, mag, and bicarb. So in reviewing this case, I said 12 lead early, but mostly because 12 lead occurred before cardiac arrest, although it was about 21 minutes after patient contact. They identified reversible causes. They secured her airway with first pass success. And then rooms for improvement. There were a few things for me. They documented that she was ice cold to touch. So I presume that the patient was hypothermic. If she's hypothermic, there's a bunch of considerations that I have whenever I'm dealing with a hypothermic patient that are a little bit controversial. So we can talk about that in the learning point for this. And then RSI choice, she's down for multiple days, presumably. She's also hypothermic, so we should really be avoiding succinylcholine and using our other agent that would be less likely to create higher potassium levels. And then what our considerations are if, let's say that she's not hypothermic and we have refractory ventricular storm. And then the other portion that I didn't put in there is that we want our antiarrhythmic agent before our epi in our shockable rhythm. So in the emergency room, they document that the pre-hospital care that was relayed to them was that she got 3 milligrams of epi, 2 grams of mag, 50 milliequivalents of bicarb, and she was shocked 5 times. There was there was some portions of her pre-hospital care that did not get crossed over to the hospital. They resumed CPR. They gave her a total of 2 milligrams of additional epi, 6 milligrams of Narcan, 450 milligrams of amiodarone, and shocked one more time before they called her code. No temperature was recorded for this encounter in the hospital. So I wanted to talk about cardiac arrest when it pertains to accidental hypothermia, so not with our therapeutic hypothermia management. So accidental hypothermia. This is whenever the core temp is less than 35 degrees Celsius, which that means that's equivalent to 95 degrees Fahrenheit. Extremes of ages, so very young, very old, people with other comorbid conditions put them in higher risk of hypothermia, as well as drugs and alcohol. Physiologic changes that occur when the patient becomes hypothermic, all of these produce a reduced tissue oxygenation. So the oxygen dissociation curve shifts to the left. There's impaired myocardial contractility, there's VQ mismatch, and there's vasoconstriction. The sympathetic nervous system initially creates more tachycardia and hypertension in efforts to create tremors or heat production, but eventually this degrades down to bradycardia. And overall, the patient's intravascular volume is decreased. A lot of this is related to cold diuresis. So in my review for this lecture for you guys, AHA doesn't give us a lot of guidance. The AHA guidelines from 2020 in regards to the special circumstances of hypothermia have 4 major points, which are pretty much relayed in this slide. But all this slide really speaks to what the European Council guidelines are, which I recognize we're not in Europe, but it also some of the other sources I found references the European guidelines. So I'll talk about the European guidelines and then I'll talk about what AHA says. So anybody who's hypothermic, we should be checking for a pulse for at least a minute to identify if they don't have a pulse, because of the fact that it may be very hard to feel a pulse as their blood pressure may be very low. We should be initiating ALS and BLS procedures, rewarm as fast as possible. So one consideration, especially because I believe in December we had a case, no, 1st of January we had a case of hypothermia from being submerged in a river, is to remove any wet clothing as quickly as possible in conjunction with resuscitating the patient. Other things that we could be doing if the clothing is not wet is to try to prevent heat loss from the head if there's a hat available or some makeshift way of keeping heat in, and then covering them up with a blanket and putting on the warmer, the heater in our ambulances when we have control of those situations. Additionally, defibrillation is considered to be less effective in hypothermia. The guidelines state that focusing should be, European guidelines state that focusing should be at rewarming the patient. And once they're at 30 degrees Celsius, which is equivalent to 86 degrees Fahrenheit, then resuming with defibrillation could pursue or could ensue. But so I think that still in the European guidelines, they recommend shocking up to 3 times if you do end up shocking a patient that's under 30 degrees Celsius, but additional past 3 is not going to be very helpful. Intubation should be considered very cautiously because it's considered to be potentially pro-arrhythmic, like jostling the patient. So recognizing that if you need to intubate, that you're potentially going to see your patient decline. Resuscitative agents such as our epi and our amiodarone and our other meds are often ineffective, and with the cold environment, it's often reducing the metabolism of these drugs. The recommendations are the European recommendations are to rewarm the patient to 30 degrees Celsius, don't give any meds, and then once 30 degrees Celsius is achieved, then doubling the interval dosing for meds until the temperature of the patient reaches 35 degrees Celsius, which is equivalent to 95 degrees Fahrenheit. And that no matter where we're at, either European or the AHA guidelines, is that ECMO would be the gold standard when it's available, and that the patients are not dead until warm and dead. AHA specifically state that besides the ECMO being gold standard in the last portion of you're not dead until you're warm and dead, they say that it may be reasonable to defibrillate these patients, and it may be reasonable to give these patients resuscitative medications. They don't necessarily speak to holding off on those or to waiting to getting the temperature of the patient up higher. So that's just some of the differences. And then as for our protocol is to remove wet clothing and protect the patient from further environmental exposure, so get them out of the environment that they're in. As you guys probably know, that if you have a patient that's in like the environmental extremes, you don't want to risk them getting colder or not being able to control their temperature. So really making sure that your patient's environment is stable. You're going to be getting the EKG and a pulse ox, handling them gently to avoid anti-rhythm or avoid rhythm degeneration, and then rewarming them. If that's warmed O2, warm packs, heat blankets, warmed ambulance, and if you must pursue cardiac arrest management in these patients, it says our guidelines say that the hypothermic heart may be unresponsive to cardiovascular drugs, pacer, stimulation, or defibrillation, and rewarming is paramount. It speaks a little bit about our at-risk populations under our other treatment considerations under C, and then also D, that hypothermia may be preceded by other etiologies, so looking for the reversible causes whenever possible. Anyone have any questions, comments about this second case?
Okay, Dr. Gadwal, it seems that no one at any level of this managed to establish a temperature on this person, correct?
That's correct. And it's just that the fact that this crew documented ice cold to touch, which is, we review a lot of cases, and when we document something like that, it means to me that this was a pretty atypical temperature check for them.
But I take it, right, and I take it that they had no way of doing a temperature check, an actual temperature check on her.
I think that from my reading of charts, it seems like either fire or transporting agencies have the ability to check a pulse ox, a temperature, and I don't, and this was preceded by fire, so I don't know why there wasn't one recorded.
Well, I know that, a cold register thermometer is actually what's needed in this, but I would think that an electronic thermometer would give you a good idea. Also, I agree with you, the sequence of the epinephrine before the amio was not what I would prefer in this. I think we should probably revise our hypothermia cardiac arrest protocol to include that restricting it to probably 3. If they don't have any result from defibrillation, restricting it to 3 shocks. Now, I noticed that they shocked this patient 5 or 6 times altogether.
9.
At least 9 times altogether. Was there any mention of changing the pad placement?
No, that's why that was the other portion, is that, if we thought that this patient was not hypothermic and we just thought that we had a refractory ventricular storm or continued VFib or VTAC, that the other consideration, exactly as you mentioned, would be to either change pad position. So we have 2 options, or potentially, if we've done those, like AP and posterior, AP and lateral, then you could also slightly move the pad in the event that we're getting better capture. If you've tried those two options already.
Placement of standard pad needs to be adjusted a little bit. The probably correct placement is up on the right anterior chest, and then way out on the at least in the midclavicular line at about the fourth, fifth, and sixth interspace. That way you capture the ventricle, the left ventricle, right between the shock. AP would be the preferable placement as far as I'm concerned, but sometimes that doesn't work either. Also, the theory of ventricular storm, if this woman was likely to be a methamphetamine user, and that this was somewhat related, perhaps she had a stroke and then is laying there for days, is that she didn't really need, I mean, epinephrine would probably be very contributory to a ventricular storm, just too much sympathetic stimulation.
Mm-hmm.
You know, sometimes the magic doesn't work though.
Yeah, no, I agree. And that is, this happened this happened a few weeks before the gentleman who fell into the river. So I thought if we would have had case reviews in December, this would have occurred beforehand. But
well, I think, and Mark and I will take care of that. We need to alter that protocol a little bit to while they're hypothermic, to establish hypothermia, and then to not continue to shock a unresponsive heart that's too cold.
yeah, absolutely. And I think that I don't know what happened in the communication with the hospital, but if you're worried about hypothermia and you're unable to confirm that, make sure that you relay that to the hospital so that we recognize that we're looking for a core temperature to determine what efforts that we're going to be using, and how aggressive we're going to be, and then making sure that whatever the treatment was, even if you misspoke in the beginning, that you can come back and say that actually no, we actually shocked this patient 9 times and we gave 6 of epi and 4 of Narcan already, so that we have an idea of what resuscitation has already occurred and that might alter our treatment in the hospital setting.
Is there any documentation, just out of curiosity, of the scene? Was she incontinent? Specifically, was she incontinent of urine? Or was she urine soaked while lying there, which would indicate to me that she might have been having a cold diuresis as well.
Yeah, they didn't document that. The only thing that they documented, and from my recollection, was that she had some blood surrounding her mouth and her lips.
And I would just say there's a lot going on in this case, but if I were to take one thing away from this, it would be don't give sucks to people who have been down for a long time. That can really put you in a tough spot.
And if they're truly hypothermic, you may not need, if they're hypothermic and unresponsive, it's unlikely they're going to compromise their airway by vomiting, etc. And you might as well try to just gently bag valve them rather than intubate them. Intubation always ends up in a VFib situation in this case.
And I was thinking about, because we tend to, if we don't intubate, we put an I-gel in, and I would imagine this too would have led, if this was confirmed hypothermia, it would also lead to.
Exactly.
Yeah. Well, thank you for both of your guys' perspective. Is there any comments? I don't see any. All right, well, going on to case 3. Case 3 was a case that was brought to me by one of my partners about concern for care. So that's why I'm presenting it to you guys today. So this is a 85-year-old female at a facility. She was contacted because of altered mental status. PP usage documented as maximum. Vital signs were obtained immediately upon patient contact. Heart rate's 87, blood pressure is 204/92, respiratory rate is 16, GCS of 14, and estimated weight of 85 kilos. Prior to the transporting agency's arrival, Fire had already gotten a blood glucose, which was 245, and they documented a temp of 99.3. The patient was found to be alert. Her airway was open and she was protecting it. Her pulse was present. She was pink, warm, and dry, and there's no signs of active bleeding. Her previous medical history included stroke, diabetes, asthma, AFib on aspirin, and hypertension, hyperlipidemia. As mentioned, she resided at a nursing facility. She herself had contacted help through her call button or her life alert, in that apparently her baseline is that she was awake, alert, and oriented, able to convey information to and from, no problem. But today she was altered from her baseline, in that they don't know, the staff there didn't know when her last known normal was, and that the staff did know that she ambulated with a walker. EMS documents that the patient has a left facial droop. She's hot to touch, but they noted that her temperature was 99. And they did get a set of vital signs that I had presented to you guys earlier. They document her LAM score is 1 for her facial droop at 7 minutes. They get a 12 lead and they start an IV. Here's our 12 lead. Appears to be narrow, not fast. And then if you're looking at intervals, they say that her PR interval is 2.20, so first degree, nothing of huge consequence. The medics go ahead and contact the patient's daughter and find out that she was speaking to her daughter the day before around 2:30 and was complaining about some diarrhea, but otherwise was acting normal at that time. So they were able to establish last known normal at 2:30 the previous day. And as you can see, it's 8 o'clock in the morning, approximately. They get another they initiate transport at 26 minutes because of her facial droop, her altered mental status, her BFAST and her LAMS. They bring her in as a potential stroke alert. At 32 minutes, they take another set of vital signs. Heart rate 95, blood pressure 174/90, respirators of 16, GCS 14, room air sat of 93%, and at 36 minutes, they make it to the hospital. So in reviewing just the pre-hospital side of things, I thought that their differential diagnosis was excellent. They did a complete set of vital signs. They got serial vital signs. They did a BFAST, LAMS. They notified the hospital of a patient that potentially meets our stroke alert criteria, with a unilateral facial droop, altered mental status in the last 24 hours of being from normal. So that meets our criteria. They did get a 12 lead. They got a 12 lead less than 10 minutes upon patient arrival. And they also took it upon themselves to confirm her last known normal, when oftentimes that isn't necessarily the case. Rooms for improvement. I actually didn't think that there was much for these guys and gals. I don't know the particular medic in the crew, but in case there's not just male partners. But anyways, in the emergency room, they identified the patient had rotary nystagmus. She was confused. She was aphasic, dysarthric, had speech that was gibberish. They calculated her National Institute of Stroke scale as a 23, so that's pretty high on that scale for us. After they sent her to the CT scanner because they upgraded her for a stroke, they brought her back to a room, and within an hour of being placed back in the room, they noted that she had a temp. She had an elevated white blood cell count because she was tachycardic, and with a fever, with elevated lactate. She met our sepsis criteria, so she was upgraded to a sepsis alert. Her workup was unrevealing, so they ended up doing a lumbar puncture, which was significant for meningitis with many abnormal features of the cerebral spinal fluid, and her cerebral spinal fluid cultures grew H. influenza. The additional information that I read in the hospital course is that the patient had a diarrheal illness. There was something going throughout the care facility, and presumably it was Haemophilus influenza that was going through the care facility. Her blood cultures ended up becoming positive for H. influenza as well. They did an echo to make sure she didn't have any vegetation or infection of her heart, and that she was discharged to rehab on hospital day number 10. In reviewing her care, a few weeks later, she came back to the emergency room for COVID, but otherwise looks like she's doing okay. So I thought this was a great case for reviewing meningitis, but also because I thought that I brought this case, or I present this case to you guys because I really thought that the crews did a great job, especially with the criticism of why didn't they identify this patient as septic. And I think that for what they had, they identified it appropriately for what our protocols outlined for them. So kudos to the crew. Anyways, meningitis, it's inflammation of the meninges. There's 3 layers of the covering of the brain, and the incidence of this worldwide is 8.7 million. In the United States, our mortality is 14.3, but globally it's 25%. So I guess if you're gonna have this condition, have it in the United States. Anyways, the causes can be both infectious and non-infectious causes, and the most common causes in the United States are going to be strep pneumoniae, group B strep, Neisseria, meningitis, H. influenza, and listeria. So our patient had one of the most common causes. And the pathophysiology could be either from hematogenous seeding or direct contiguous spread. So hematogenous spreading or seeding would be like an infection in the nasal passages that gets that crosses through those sinuses into the blood, and then seeds that way. Or direct would be like surgery or in like an ear infection that translocates through the bone into the meninges. That's kind of the differences between the two. The signs and symptoms are going to be variable depending on the etiology, but the patient may present with light sensitivity, fever, neck stiffness or nuchal rigidity, headache, confusion, irritability, or just be vomiting. Physical exam, it's really important on these cases of meningitis or any type of cranial infection, either encephalitis or meningitis, to do a good neuro exam. Up to 10% will have cranial nerve abnormalities. They'll have potentially meningeal irritation, which is these 2 figures on the right. Brudzinski's is going to be when there's severe neck stiffness causing the hip and knees to flex whenever the neck is flexed. And then Koenig's is going to be pain with passive extension of the knee greater than 130 degrees. And they may have a rash, but that's specific to one particular bacterial infection of the meninges, where it's a non-blanchable purpura. The diagnosis for this is going to be a lumbar puncture, and the treatment, if it's infectious, is going to be antibiotics. And then for our region's protocol, the best I could find that this would fall under besides a stroke would be altered mental status, so universal patient care, and then our altered mental status and coma protocol speaks a lot to glucose and opiate use. The glucose was checked with this patient, and as we all know, altered mental status has a lot of potential etiologies. Anybody else have any thoughts or questions about this case?
It's a pretty interesting presentation. It's interesting. Haemophilus influenza used to be the most common cause of meningitis in infants, in children from their ear infections. But now we immunize children against H. influenza. And as a salutary effect of that, you also get That's also reduced the risk of epiglottitis in children because epiglottitis was caused by H. influenza as well. The most common cause of bacterial meningitis in Clark County is from strep pneumonia. We used to be the #1 reporting county on the West Coast, probably just because we reported it well. But back in the 80s, we were the winner on the West Coast for reporting meningitis, meningococcal meningitis, the type A strain. But that has since fallen off. I've only seen one case of meningococcus transported, and that was last year by AMR from a homeless camp, which the guy also had. He was methamphetamine overdose, as well as which gave him a seizure on top of his meningitis, on top of his COVID positive. I don't even know whether he made it out of the hospital.
He did. We presented that in one of our case reviews, but yes.
So,
Yeah.
and it's an interesting thing. We don't see a lot of meningitis or with that, except from strep pneumonia now. The nice thing about strep pneumonia is that even if you were accidentally exposed, unless you had some sort of immune compromise, you have no risk of picking anything up from a patient who has strep pneumonia meningitis.
That's good. Yeah, and it's a reminder too, just because we have such a large population of individuals that don't vaccinate their kids, that although a lot of other places don't have the same issues, we may because of our unvaccinated population. All right, last case of a 3-year-old male. EMS gets contacted to make contact with the patient for a seizure. PPE usage documented as maximum. Vital signs were obtained at the onset of making patient contact, noted to have a heart rate of 161. Blood pressure was not taken. Respiratory rate of 18. GCS of 3. SATs of 100%. And the patient, I don't know if they estimated or if they used a Broslow or another device to confirm the weight of this patient, but they do 16 kilos, which for a 3-year-old is exactly where you'd expect it to be, in that the vital signs is only significant for tachycardia, as the heart rate for this age group would be a maximum of 120. The patient's unresponsive, the airway is open, he's not protecting, pulse is present, there's no signs of active bleeding, and the past medical history obtained is that he had a febrile seizure earlier in the year. This kid was December last year, so earlier in the year, like March. The history of the present illness is that he abruptly got sick the night before with a fever and a cough. He started seizing 45 minutes prior to EMS arrival, and he just hasn't stopped, and that there's no reports of trauma. So they get this call at 6:51 in the morning. Vital signs, as I had mentioned previously, at 2 minutes, they get a temp. He's 104. They give him 2.5 milligrams of IM Versed. At 6 minutes, they check a blood glucose. They do note that he's still seizing and he has a leftward gaze from the initial patient contact. At 9 minutes, they establish an IV. They give him 250 cc's of IV fluids. At 10 minutes, he gets another dose of Versed at 1.25 milligrams IV. They place him on a non-rebreather, and they get another set of vital signs at 15 minutes. More tachycardic than previously, now 183. Blood pressure is not taken. Respiratory rate of 12, GCS of 3, and they're bagging him. At 16 minutes, they move forward with intubation, giving him 24 milligrams of ketamine and 20 milligrams of succinylcholine. At 17 minutes, and they were successful at 17 minutes with video laryngoscopy, first pass success, placing a 4-5 ET tube and documented end tidal of 68. At 22 minutes, they give him his first pain portion of his sedation, 32 micrograms. At 25 minutes, they take another set of vital signs. Heart rate's improving a little bit. Respiratory rate is at 26 bagged. 29 minutes, they take another set of vital signs. Heart rate's improving again, 165. They get a blood pressure 133/61. Bagging him at 28. And at 30 minutes, they initiate transport to the hospital. They note that his end tidal is rising from 68, now 78. At 31 minutes, they do another pain dose of sedation, 32 micrograms of fentanyl. And at 33 minutes, they give him 4.5 milligrams of ketamine. And at 39 minutes, they give him his third pain dosing of 32 micrograms of fentanyl, and they make it to the hospital. And then equipment wise, I just want to make sure, yeah, 4-5 is the proper tube for this kid. Anyways, the good in reviewing this case, early set of vital signs, anti-epileptic drugs were initiated. The blood glucose was checked early on. IV access was obtained. Second dose of anti-epileptics were administered. And after a pretty significant amount of time, 17 minutes, they move forward with intubation as opposed to doing it immediately to give the patient a chance after the two Versed doses to see if he would stop seizing, which from what I could gather, I believe from what I can gather, he stopped seizing after the second dose. He wasn't seizing throughout the rest of the transport. And then room for improvement, the RSI med dosing reference use, the meds were just a little bit off, and I asked what were they using to look it up. I think that probably, I don't know, it's probably not in our documentation protocol or documentation guidelines to say what your reference material is for looking up your pediatric dosing and values, but it's always helpful for me to know, if we always use Broslow, if you deviate, what you use to guide your resuscitation. So in the emergency room, the kid was still febrile, 100.7. His chest x-ray revealed that he was right main stemmed. So they pulled back the ET tube. They did a CT of his head, which was unremarkable for any acute processes. They did an LP, which also was not revealing for any type of infectious process, and they transferred him to Dornbecker. I'm not sure if his viral panel came positive at the hospital that he was initially at or at Dornbecker, but he was parainfluenza positive. He was extubated shortly after arrival at Dornbecker. He was monitored in the ICU for 6 hours, where he returned to baseline, and he was discharged that same day with a diagnosis of complex febrile seizure with neurology follow-up. And then looking at the neurology follow-up, they did not start him on any anti-epileptics. So I guess first off is that I thought that I put this case in here for us because I thought they did a really good job on a critical patient that was, for all intents and purposes and status, refractory to treatment. So just a reminder about status seizures. This is a condition where you have a sudden spike in temperature greater than 38 degrees Celsius without an underlying epileptic cause. And the highest fever necessary is specific to the individual, so it's not necessarily a threshold that we should be looking for. Usually it has to do with the spike and the rapid rise in it. Febrile seizures may be the first sign that there's something wrong with the child. In this particular case, the kid had a cough and fever the night before, but sometimes these kids just present as a seizure and the parent wasn't aware of any other issues, and then you find that they're also febrile, and then gather a little additional information, and they recognize that they had URI symptoms that they weren't necessarily aware of consciously. The demographic is going to be 6 months of age to 60 months, and the pathophysiology is unknown, but there is a genetic predilection. So a parent with multiple children, if one child has a febrile seizure history, the odds are higher for subsequent children. And then same with like the parent themselves, if they were a child of febrile seizures, that their children may also. And then the types of seizures are going to be simple. These are the ones that we typically see, which are just generalized, tonic-clonic, lasting less than 15 minutes and doesn't reoccur in that day period, and they return back to normal. These are patients that we oftentimes will see and give them reassurance. We don't image them. We don't necessarily get blood work to work them up, but it's our complex seizures that are the ones that we really want to be aware of. And these are ones that have focality, so not generalized. They last greater than 15 minutes and they reoccur in a day period or a 24-hour period. So these ones warrant further workup, even if the history of febrile seizures, if your patient has complex complex form to their seizure, they should be transported and evaluated. Treatment is going to be anti-fever meds, although it's not been shown to prevent reoccurrence of a seizure, in that sometimes these kids will be started on benzos or anti-epileptics. Reminder that febrile status seizures are going to be lasting greater than 30 minutes, and they represent a very small portion of these kids, less than 10% of the time of the first time febrile seizure presentation. In that the treatment would be rectal diazepam if you have it, if the seizure lasts for more than 5 minutes, or intranasal Versed. So our protocol for seizures, if the patient's is having a seizure, our options are midazolam, either IV or IO, and if no IV access, and this is for adult, these are the first part's obviously for adult, and if no IV access, is that you have the option of giving Versed 10 IM and repeating every 5 minutes until the seizure stops, making sure that you're monitoring the patient for respiratory compromise. And then you can check a blood glucose and consider your altered mental status workup. If the patient is seizing because they're pregnant, then consider eclampsia, and place that patient on the left side and treat them with MAG. For pediatric patients that's in a seizure, again, they have the option for Versed, IV, IO, IM, IN, and treat their fever if their temperature is above 100.4 with Tylenol. Anybody have any questions, concerns, thoughts for the last case?
I noticed that just a quick calculation, if this child was indeed 16 kilos, the dosing of Versed was underdosed, giving him, it would have been 3.2 milligrams his first IM dose, and that could have been repeated 5 minutes later.
Where's IN? Yeah.
Is it 0.2 milligram per kilo, and at 16 kilos, that's a quick check of 3.2 milligrams. So perhaps that might have.
In my recollection too is that the RSI dosing was a little bit less too.
Yeah. So just a reminder, if you're going to, underdosing often means that you have to do repeated dosing.
That's a good point. Well, in summary, thanks for your guys' attention. We talked about malaria. These are mosquito-borne, where these are patients that are either from an endemic area or vacationing or traveling back to an endemic area. And depending on what type of plasmodium infection they have, they could have symptoms up to a year after they return. And that, interestingly, the prevention is really just long sleeves and sleeping with a mosquito net. I read a lot about potential other prophylaxis, but they're not as common. So know where you're going and take the necessary precautions, and notify or alert the healthcare team that you travel there if they hear the person that has these symptoms. in that if you have a patient that, or if you're a patient that has a fever and flu-like symptoms that are not finding a diagnosis and you've traveled to this area, that the lack of appropriate treatment is high risk of mortality. So being persistent like that patient was, keep on presenting. And then hypothermia, we talked about accidental hypothermia, cardiac arrest management, recognizing that we really want to do everything we can to prevent any future or further heat loss, as well as trying to get their temperature up as best as we can in the pre-hospital setting, recognizing that our interventions may cause them to degenerate into VFib or VTAC. So being really mindful about how we handle them, if we absolutely need to intubate them or place an IG-gel, and then consideration of if they are in a shockable rhythm, how many times you're going to shock them. And the goal is to really get that reheating portion started aggressively as possible. And then maybe considering limiting the meds given, or at least spacing out the timing of them, and that you're not dead until you're warm and dead. Meningitis, that this is a great reminder that it's an infection of the meninges, not the brain itself, and that there's some signs and symptoms that might help cue you into that and some physical exam findings. But ultimately, these patients can be difficult to identify. They may be mistaken for other neurological problems, but these patients should come to the hospital. And then status seizures in a febrile patient, identifying them have a seizure, trying to lower their temperature, and then recognizing what your options are for anti-epileptic management for these kids, and that the chances are high that they'll have another febrile seizure next time they're sick, at least until they're like 5 or 6 years old. All right, that's all I have for you guys.
Thank you.
Yeah,
Thanks,
thank you.
Dr. Gabois.
I'll just make sure there's no comments or questions real quick. I didn't see any. Did you? No. All right. Thank you guys.